Yeah, I
Isabella,
a little bit.
Joe, can you hear us?
Yes.
Carlos Fedra from Milano.
Yeah. Yes, hello, it's Giovanni here, and Isabella, and
Hello guys, welcome back.
and Alessia, and we're doing the second case here. It's quite a complex case, and we will explain to you the details of the case. But before we do that, we'd like to show you some of the angiograms from the previous case, which was the coarctation where we did a CP stent, and we had no gradient. But Joachim Miro noted, and we noted too, that there was recoil. And initially it looked good, but over a few minutes of wait, we could see that it was pinching a little bit more. So can you see the floral of the stent?
Yes, we do.
Right, so you can see it got pinched a lot more in the center rather than just flared distally. So, la prossima, per favore. See, so we used a 20 Mullins balloon. La prossima. And l'altra, l'ultima. Okay. So this is how it looks now. So you can see it's nicely uniform. The left subclavian is still patent, very nicely so. And it is a much better result. So the suggestion was taken up, and I think with a good result. However, the patient...
How much pressure did it take?
Pardon?
How much pressure did it take to open the lesion?
Well, we went up to 10 atmospheres, and at about 8 atmospheres it went.
Good.
So the problem afterwards was that the patient developed quite a bit of chest pain. So we sent him for a CT, and there was a small left pleural effusion. He's very stable clinically. He's got peripheral pulses in all his limbs. He can move his legs, and there's no problem. But the concern obviously is whether there is a dissection or a rupture that's not being completely contained. So we're going to repeat the CT scan later on today, and we'll either manage him conservatively or we'll do whatever is appropriate. But it's been several hours now since the procedure, and he's been very stable. Any questions on that?
No. Me, Martin here. Just a remark. You should indeed be very careful and repeat that CT angio in a few hours. We lost one patient, and I showed that 2 years ago here. Actually, it was a Turner syndrome. She had a high risk. It was a recurrent coarctation. It was the ideal dilatation stenting of a recoarctation, and she bled to death in the beginning of the evening.
Right.
And we could not keep her alive. So
right.
Keep a very close eye on this patient.
Thank you very much. Yeah, we will do that, and we'll keep the blood pressure down. We'll keep him starved in case we need to do any intervention. So we're taking it seriously. And if there are no further questions, we'll pass you on to Alessia, who will present the case that we're doing at the moment. So we're just waiting for the slides to come up on the screen. There it is, Alessia.
Okay, can you hear me? Okay.
Yes, go ahead.
This is the second case of a 19-year-old male patient with the diagnosis of corrective transposition, VSD, pulmonary atresia, post-surgery with the LVOT obstruction LPA stenosis. The next slide, please. In the age of 1 day, he underwent a right modified blood octasis shunt, and subsequently a second central shunt was made with the surgical plasty of the left pulmonary artery. Finally, at the age of 3 years, he underwent a surgical correction. The LV was connected with pulmonary arteries with a composite conduit made of a 16 mm semi-shield plus a monocusp patch derived from an homograft implant. Shunts and VSD were closed, and a small ASD was left open. Next. Recently, he is complaining of mild dyspnea and exertion, and stenosis of LPA and LVOT were noticed. The body weight is 55 kilograms. He has a 3/6 systolic heart murmur. He underwent a cardiopulmonary stress test. We showed a reduction of exercise tolerance and the oxygen consumption and oxygen desaturation during the stress. Echocardiography shows a mild residual ASD, a moderate tricuspid regurgitation, mild mitral regurgitation. The systolic LV pressure is estimated as 110 millimeter of mercury. That is very similar to the systemic blood pressure, but LVOT and pulmonary branches couldn't be well visualized. Here on CMR, you can see a small interatrial communication. Next. The ventricles are well functioning. Next. Aorta has a mild regurgitation. Next. Here you can see that there is a tight stenosis of the LVPA conduit, and the regurgitant flexion is 21%. Yeah. Again, the measurement of the conduit with the narrowest point, which is 7.4 millimeters, and the length is about 25.5 millimeters. Next. You can appreciate the anatomy of coronary arteries and the right coronary arteries that passes between the aortic root and the LVOT artery. Next. Pulmonary branches, while the right one is good in size, the LPAs has a tight stenosis at the origin. Diameters are 8 per 5 millimeters, and a reduction of the flow to the left lung. The next, here are other images of the two branches. Next. So the intended procedure was stent implantation in the left pulmonary artery, melody valve implantation in the left ventricular outflow tract, and on the bait SD closure.
Right, thank you very much, Alessia. And what we've done so far, we put lines in the groin, and we entered the left ventricle, morphological left ventricle. But to enter the left ventricle from the right atrium, the angle was really very acute. We had to go to the ceiling of the right atrium. And we figured out that if we're going to put anything like big sheaths and stents and valves, this was not going to be very helpful. So we changed entry, and we went from the jugular. The right ventricular pressure, the left ventricular pressure, which is the morphological left ventricle, the subpulmonary, was suprasystemic. And we did an angiogram of the main pulmonary artery, which we will show you. We can show the angiogram of the pulmonary artery. Okay, so you can see this is a caudal view, which is very similar to the CT angio or the MRI that we had. And you can see the right looks good, but the left has a tight stenosis, and it's also folded on itself. So, and there has been a surgical patch there. We've had great difficulty keeping in or putting in a sheath without kinking here. Eventually, we put in an arrow flex inside a Cook Mullins sheath, and over a Lindequist wire, we managed to get the sheath in the left pulmonary artery distal to the stenosis. As you can see from those angiograms, we even tried the balloon technique to pull the sheath forwards, but we couldn't cross the stenosis, and there was a lot of kinking of the sheath. We did not have a large flexor sheath or a braided sheath, and if this did not work, Isabella suggested that we use an AGA sheath, and we would have done that. So the short of it is that we placed a stent in the origin of the left pulmonary artery. We used an Andra stent XL 21 millimeters. We wanted a short one. And we mounted that on a 12 millimeter balloon. That was a ZMed 2 balloon. And you can perhaps now see the angiograms of the positioning of the stent. La prossima. Next one. Okay, next one. And that's the result so far. We thought that at this point we should probably dilate it from 12 to 14. I think that we can also probably put a stent in the RV outflow, the LV outflow tract. But whether we will be able to also put a melody depends really on the course of the wire. We would plan to put an 18 melody at some stage. We want it to be a bit restricted so that we keep the alignment of the septum a little bit midline.
So what was the original diameter of the conduit?
16.
The homograft?
The homograft was 16.
16.
Yeah.
So where are you now? Are you finished with the stent?
What we've dilated it to 12 and we're going to dilate it to 14. And then once we've done that, we will put a stent in the RV outflow tract.
Okay, any questions from the audience? There's Bill.
So, just to be controversial, if you've opened up the LV stent and your LV pressure is at systemic levels in this lesion, why do you need to open up the obstruction?
Well, the pressure at the moment is equal to systemic.
Yes?
Would you be happy with that?
There are quite a number of patients with systemic LV for an anatomic LV that are absolutely fully functional, have no restrictions, and with perfectly normal function.
Yeah.
You are maintaining alignment of the septum by having higher pressure in the LV.
Yes, of course.
So I'm not sure I know the right answer, but if there's any difficulty in opening it up, I'm not sure what the benefit is lowering the pressure below systemic levels in an anatomic LV in this situation.
Yeah. I mean, we normally, when the surgeons go in to try and band these patients, they normally go to about 60-70%. Now, again, I'm not sure whether there's any science in that, but it seems to work in terms of aligning the septum and reducing the tricuspid regurgitation.
And I absolutely agree with that. The question is, I'd like to know what the pressure is after you've opened up the LPA.
All right, let's
and if it's subsystemic.
Yeah.
And I'm not saying I know the right answer, but is it necessary to do anything?
Okay, so we've got the balloon across the stent now. This is a 14 millimeter one, and I'll just push it in a tad further, and we can inflate it there. Yeah, just inflate. Yeah, we need a calabresa here, a strong calabresa. Come on, Cataldo, come on. Okay, deflate, bravo. Okay, so we'll in a minute take the balloon out and do an angio and measure the pressure approximately. Spinge la guida. La guida, bravi. Okay, so let's do an angiogram and through the side here, come prima, un po' di contrasto acqua e facciamo la misura della pressione. 20cc, sì, grazie.
Is Barbara Motor here?
Okay.
No.
Buono.
Ready to apply? You have it. So, did you see the angiogram there? Let's clear it, got the pressure.
Yeah, it's clear. Nice result.
So I think it's a very good result. There's no extravasation, and I'm very happy with that. You know, it was a short stent deliberately, but I think it's worked very nicely. And I do like these andro stents because they, for curvatures and strength, I think they're very good. So let's measure the pressures simultaneous, please.
La pressione mi devi dare questo.
If we can show them the monitor, please. The monitor. La pressione.
Camera.
Non completamente, anche noi possiamo...
Ci fai vedere anche a noi.
Ce l'ha fatta
So, can someone read the pressures for us?
70 and 80 in the femoral artery.
So the femoral artery is 85 over 47, and the pulmonary artery is now subsystemic, and it's 68 over 7. So that's reduced the pressure, which I think supports what you've been saying. And the question is really whether we leave it at that, or whether we should simply stent the conduit. We may just leave it at
There are
that.
some comments, Joe.
Yep.
There's some comments.
Welcome.
You and Evan.
Yeah.
I just think you've got a great result for this patient, and I wouldn't meddle with this at all. Is the pressure in the LV the same as this pressure?
So sorry, the LV pressure.
Yeah.
Yeah, we're going to do our withdrawal on this on the wire and with the sheath. So let's do that now. Okay.
So do you imply that the
Vogliamo
to the
pull back quanto?
I'm not sure, but I don't think this, with normal function on the anatomic LV, would cause symptoms. It may be the anatomic RV, which is not normal. All kinds of reasons for that. I don't think you get much better than this pressure if that's in the LV in terms of left AV valve
Right,
function.
we're still in the pulmonary artery. Let's do a withdrawal for you from FBA to LV. So we're starting at 63. I'm putting the sheath over the Lundquist wire, and the pressure has gone up again, and we are suprasystemic again here.
Normal.
Yeah.
Or just suprasystemic.
Can I make a comment?
Yeah, it's clear. Evan, go ahead.
So, Joe, this is Evan. I was sitting over in the corner with Frank, and I don't know if this will influence your decision making. I personally would probably be tempted to do something as you are, because I don't think it's just a matter of the ventricular mass. I think the conduit is very restrictive for this patient's size, and he probably can't increase his cardiac output no matter what ventricle is under that conduit, because it's just restrictive with exercise. But having said that, I don't know if this will help or hurt, but this conduit is to make this bigger, you have to go all the way out to the bifurcation. If you put that angiogram that you just took again.
Yes, can you put the last angiogram again, please?
The conduit is smaller than each branch.
L'ultimo angio, per favore.
Yes, so it currently measures around 11 millimeters, or 11-12 millimeters.
Yeah, and I guess, from a technical standpoint, to me that makes it very, very challenging to get it open all the way to the bifurcation, and as well as sort of bumps up the risk factor a little bit. I'm not saying it's not doable, but I think in addition to him being corrected transposition, access from the neck, you start to add up relative risk factors and difficulty level, and I think the angles you're going to have to deal with, and the fact that you have to get right onto both branches, because that conduit's tiny, right at the bifurcation, it might just be there's too much to get done, and I might consider sending this patient if you think he needs something. I think he does for surgical conduit revision. Something to think about.
Yeah.
Evan?
I can see
I was just trying to work out from your pressures
The earlier pressure you showed was 65.
That was in the PA
in the main. Yeah.
proximal to the
What
stent.
I'm trying to work out is why the main pulmonary artery pressure distal to your conduit is so high.
Well, the RPA pressure distant to the conduit was low. I think it may be that we're getting a bit of a hybrid pressure because we're very close, as Evan says, between the conduit and the MPA. So distally, both pulmonary artery pressures were low. So this patient is not hypertensive.
He's got two areas at least of obstruction.
Yeah.
The pressure is from where the tip of the sheath is now, so you're seeing the distal obstruction. Then when he comes back to the ventricle, you
Exactly.
have
So I think if I were to push the sheath forward, I'm sure that the pressure distal to the conduit is going to be normal.
Well, you could try and pass a multi-track and see what that pressure is distally.
Well, we can, but the sheath is kind of multi-track in itself, isn't it?
Yeah, but you haven't got to where you said near the bifurcation.
Kevin?
Joe, nice job on the left pulmonary artery stent. Which bit of this conduit, which I think is a composite, which bit is actually the hemoshield, the 16 millimeter hemoshield?
Well, I think what they've done is they've put a patch on the pulmonary arteries, then they put the 16 millimeter hemoshield, and then the last bit between the RPA and the conduit, they covered with native pericardium.
So is the hemoshield the little bit in front of the bifurcation?
Yes, I think so.
So that's not really going to get any bigger, is it?
I don't know how stretchable it is, but we would be happy with 16.
The point I was trying to make was if you know what the pressure is now, just where that bifurcation is in the stent, and if it is low, then if you're going to stent, you're going to have to stent all the way back from that bifurcation into the left ventricle, and that is going to be a very difficult, challenging thing to do if you're going to get there at all.
Yeah, I mean, I think
I think Bill's probably right in terms of not interfering too much.
Yeah. I mean, we may well have to put, a body wire and in each pulmonary artery to deliver a stent in that position, so it doesn't move beyond the bifurcation.
Okay.
Any other thoughts?
No, we are running a little bit behind, so we have to go to the talks, and
that has been
come
very.
back to you. Is that fine?
Yeah, that's fine. That's been very helpful, and we will give it another discussion and see how far we go. But I think it's been a very, very helpful discussion. So I'd like to thank all the staff here in Massa, especially Isabella, who did a lot of the organising. But also we need to thank Fabio and Claudia from Abi Medica, who have been supporting the cases today. So enjoy the rest of the evening, and hopefully we might see you for dinner.
Okay. Thank you, Joe.
Enjoy it.
Thank you, Isabella.
Thank you very much. Bye.
Bye-bye.